different roles. One of the main things in quality improvement in healthcare, whether they call it quality management or quality control or quality assurance, people often get a misunderstanding that just by doing good things is quality improvement. In 1998, the Irish Society for Quality and Safety in Healthcare, which I was then the director of, put together a book of quality improvement techniques and that were going on, or quality improvement projects that were going on throughout Ireland. Unfortunately, what we found were a lot of them were good things that were happening, but didn't embody quality improvement techniques, as quality improvement is a very scientific approach rather than just making something happen. So what we want to try and do this morning is hit on some of the key aspects, and it interacts with different methodologies and different ways forward. The first thing that I want to do, hopefully now the slide will move on, yes. The first question that I want to pose to you and for your consideration is really how much time do we actually spend doing what Don Berwick refers to as non-real work. And non-real work is essentially where we are doing things that do not add to the overall value. They do not add to the outcome. So there on that slide we see on the left-hand side some therapist who is doing the day-to-day work that they should be doing, and then on the right spending time looking for charts, finding out where people have gone to, people ringing in sick, chasing up supplies. This is defined as non-real. And from experience, when we run workshops with staff within hospitals and healthcare organizations, we find that they feel that they can be doing non-real work anything from 30% right up to 90%. But the most common is about 50% of doing things that they feel add no value to why they are there. And the reason that they feel when we discuss that more is that although these problems have been addressed or looked at in some shape or size along the years, that they keep coming back. And the main reason why these problems keep reappearing is the fact that the problem, the root cause of the problem has not been addressed. That something has been changed, but that change is not specifically where the problem lay. So as a result of that, we see that we have a reoccurring situation where there's a problem, people get involved, they solve the problem, but yet again the problem comes back. And in a way, many of these problems are solved by line managers or senior managers who say, okay, here's the problem, I know the organization, here's the solution. But unfortunately, that style of old school management has often been a difficulty with regards to actually making the improvements. The basic concepts of quality management move away from the old style of assurance management or knowledge management in individuals to actually looking at something. And if you concentrate or if you read anything on Duran's models, you will see the same type of information coming across. And the same basis for quality improvement in healthcare is based on these quality management principles. The first principle that we need to look at a problem when we're presented it is that people who know are the people who do the work. Again, going back to the basic concepts of quality management in Duran and in Japan, the difficulties were that the senior managers, because they were senior managers, actually felt they should automatically know what the problem is, when in effect it is the frontline staff who really have the thorough understanding of the process and thus can identify where areas are of concern. The second point was to fix the actual problem. This is the most common reason why quality improvement initiatives or process re-engineering or lean techniques or any of the phrases that are used often fail, because they do not address what the core problem is. They may look at problems that are overall or that have a relationship to it. If we can fix that actual problem, then we can reduce the refix. And the refix is this common occurrence which we see in all health systems, where we're continually looking at the same problem again over a number of months, weeks, years. The next point there, the fourth bullet point, when we say we fix what we can. Another problem that we have seen personally is that projects often start to expand and take in much more wide-ranging areas. When the need to keep the focus, it is very important to keep focused on what the issue is and not get distracted by other areas. The process approach is the key aspect in general quality management techniques. This is no different in the healthcare system. We need to be able to look at what are the actual breakdowns of the processes. The problem we have, and we've identified over the years, is that everyone feels that they know what the processes are and therefore can jump right into the solution aspect of it. Where we get people to slow down and say, let's try and identify exactly what these processes are, we then are in a position to break it down and look at the actual problem. The second last point there is about involving others, which is linked to the very first point about people who know. And it is about looking at, in healthcare scenario, multidisciplinary approach. In the last 20 years, I have yet to see any problem which was unique to any one discipline. It often has multifacets, multidisciplines who need to be involved in it, and how do we get those involved? What we find with regards to those 6 points is that they overlap, and that if we use very simple tools and techniques, then we can bring those all about. The tools and techniques that we're discussing in this presentation this morning are linked to a framework that Joyner uses with regards to the 7 steps. And you'll also see some familiar models such as the plan, do, check, act cycle as well. So what we have today, talking about the tools and techniques of quality improvement, are the core basis of all quality and safety management. Over the years, different terminology has arrived, different methodologies and focuses. We have different areas such as, be it clinical audit, be it risk management, be it health and safety, be it governance, clinical or otherwise. But essentially the concepts are the same, that we can use those points that we just discussed in the last slide, and that we can maximize them to actually bring improvement, an improvement that we can measure. And that concept of improvement that we can measure is often lost. Within the health systems throughout the world, there is often a lot of change, and the result of that change is a perception, a belief, or anecdotal evidence that improvement has been made. True quality improvement is not that nice, fluffy feeling of things are better now. It is hard, it is scientific, it is simple. It is a case of mathematics, data analysis. And for many, that concept of using numerical and techniques is not one that fits readily. Unfortunately, in quality improvement in healthcare, in a lot of organizations, people have graduated into the position without any formal training. They may have come from nursing or clinical background, but the concepts would not have been embedded within it. So within quality improvement, this is something that we try to ensure and reinforce. So it is a simple steps that need to be taken. It is scientific. It uses numbers. It uses data analysis. But most importantly, it's structured. And we always say it's a bit like Sherlock Holmes. You have to investigate. You have to find out. And the most important place to start off when you are investigating these things is you don't know the answer. There's an ongoing discussion that people who are involved in the process are either the best people to be managing a quality improvement technique, or they're the worst. And I think it's a little bit of both. But no matter who is championing the improvement, it is important that they come with an open mind and make sure that it is a case where they can approach things differently. So the 7 steps of what we're going to talk about today, we've integrated into the plan, do, check, act cycle, which is the most common improvement cycle in any aspect of quality improvement. So the PDCA cycle, or in some states it's called the Plan Do Study Act cycle. For us, we often see PDCA usually stands for Please Don't Change Anything. When we start to get into organizations, they're quite happy to leave it as it is, but it is something that we utilize and break into the different areas. So as I'm going through the presentation this morning, what I am attempting to do is to consider one specific initiative. And following on from this, and we can forward on some more additional documentation, what I would like the attendees to consider is one specific area that is causing a difficulty and how they can utilize these practical tools within that improvement project. So what we are going to look at is how you would select a specific improvement initiative. And to demonstrate quality improvement abilities and worthwhile, we often recommend to an organization that it should look at up to 3 key quality initiatives each year, above and beyond any of its regulatory requirements or legislative requirements, specific improvement initiatives that staff can get involved in. And we'll talk about that in a minute, about how those projects are actually selected. The big aspect, though, while we're still in the plan of the PDCA cycle, is to understand the situation. Before we even try to break down the cause analysis and why is this problem occurring, we actually need to understand how the situation takes place on a day-to-day. The do part of it is usually the part that everyone runs into. Everyone wants to be developing solutions straight away. What we would argue is that the planning is where the key amount of time should be spent. And if you get the planning and the understanding and the evaluations correctly, then the solutions become a lot easier. They take more time to bed down, but they do become more focused in relation to it. When we get into the check, we're back to what I mentioned already, which is that we need to be able to monitor and evaluate the improvements, not anecdotally, but quantifiably. There are very little things in this life that we can't put numbers to. It's just a way of monitoring exactly what we had hoped to get out of it. And finally, following on from that, heading back into the cycle again, is how we hold the game, and that the initiatives, which is a very common problem, can slip back, and that in the future that we can look at those initiatives again to actually see that they will not slip back and move forward. So based on those steps, step 1 is planning the project. So what we want to do, and our goal, is identify what the problem is. And why I've stated there not the solution, it is most common, and we've seen it in a number of initiatives that we've been involved with throughout the years, is that people say, we are going to solve a problem and this is the solution. So I'll give you a simple example. One problem that was presented to us is that we need to restructure our patient records. So the quality improvement initiative was to be restructuring the patient records. However, when we started to discuss that in a little bit more detail, we said, well, why? Does the lack of structure within your record itself cause a problem? What is the actual problem? And the actual problem is not about a structuring of record, it is that they cannot find the information within that record. Unfortunately, as a result, they jumped to the conclusion that it is because the record was unstructured, without actually knowing that that was the core root problem. If that record had gone ahead and been restructured, what they may well have found out, although more than likely have found out, was the case that it was not the structuring. It could have been multiple reasons. It could have been lack of education on how to input information. It could have been poor handwriting. It could have been lost charts. So it is to identify what the problem is before we start jumping into it. And usually there's a little bit of panic about what the organization will want to do and how big the project is. But yet, when we start to break it down, the projects themselves become quite small. When we're identifying a problem, Donabedian's concepts of structure, process and outcome are usually good places to start. And our initiatives can be related to either one of those, but it is usually an initiative related to structure and process, and that the outcome is what is indicating where those improvements need to be made. So it's something that links to it. So if you're looking at your organization and you're saying, well, this year we're going to look at 3 core quality initiatives, how will I select them? And often we have organizations where the staff themselves put forward ideas with regards to what type of project they'd like. So areas to consider if you're selecting that project is local concern. Because what you want to try and do is you want to try and prove to people that this technique, which takes a little bit of time, it does take people's input, but is worthwhile, and we can prove that it's worthwhile. Well then, if it's a local concern, you're selecting a good project. Other areas to consider are variance, high-risk issues, or something that comes as a priority from external, for example from accreditation or regulation. If you are narrowing down, you should always look at what are the big risk issues, what are cost, volume and frequency. Unfortunately for many, when we look at quality initiatives that occur, they're on the softer side of care. Comfort, surveys, etc. Your quality improvements should be specific. They should be focused on the care or the service that you provide, and should have a real tangible impact in relation to it. My slide doesn't want to move. Sorry, Joe, can I have control back again? Okay. Okay, when we start to look at the projects, we identify that there are a lot of resources, or maybe not a lot of resources, and people often say, well, how much time should I allocate to these quality improvement initiatives? And the answer to that is as much time as you can. Sometimes it's a little, sometimes it's a lot, depending on the initiative. But it's always worth remembering the Pareto rule, the 80-20 rule, which basically says that when we look at all of the improvements that we need to make, we need to focus on what is important. And that basically says that 80% of the actual problems are 80% of the negative occurrences are usually related to 20% of the actual problems. So we don't have to start solving everything. At the end of this presentation, we also talk about the rough laws of economic laws of quality. And it shows that the last 10% of any quality improvement, trying to get it over the line to very minute details, is what causes the time and finances. And really what we want is the big wins, the big areas to improve upon, because we don't have that time. So there are many things that we will require. The most of those, as you'll see from that slide, most importantly are the people. You will require staff's time. It is worth remembering, if you do this for the first time, you will have goodwill on your side, but you need to show success. If you can't show success after the first year, well then you're going to find it very difficult for people to go back. So for yourself, obviously this morning we're not going to do it, but if you have an opportunity after this, try and determine what will be a good project within your organization based on those things. The second aspect of it, and we're still within plan, is trying to understand the current situation. And if you are to take only one thing away from the presentation this morning, it is this, that when we go into a situation, we do not know what happens. It doesn't matter if you've been working in the organization all your life. What you find is when you start to break it down, it will be different than what you expected. Over the last number of years, we have been doing this mapping of processes, and not in one instance have I had a room with more than 2 people all agree what the process was. They're all looking at it from different points, and they all usually have a different understanding of it. So what we want to know is what is involved in this process, who is involved in it, what information, and as a result, what can I do about it? The most common thing that we do in this regard is brainstorming, and brainstorming for many is something that's flipped over very quickly, as they feel it's a case of people standing around having cups of coffee and a chat. In effect, it is necessary to try and get that opportunity with people to extract the information from them. The ideal brainstorming scenario, which then leads on to our process flow charts, are results of getting groups together, depending on the size of the organization. So process flow charts, for me, over the years, are the most important tool that we have ever used. And many people shy away from them because they think it's just about drawing boxes. And yes, it is about drawing boxes, but it gives a very clear insight and knowledge to how processes are actually occurring. And it is much more difficult to see the linkages in a text document than in an actual diagram of process flow. So when we're documenting our process flow, we get the opportunity to see who's involved, where does it happen, what risks, are there areas of bottlenecks, etc. So it provides us with a good piece of information. And we have a very simple process flow chart here. You might notice it's not exactly related to healthcare, but it's the same concept, breaking down each stage. And I'm very familiar with the buying shoes scenario on Saturdays on a regular basis. I might add not buying my own shoes, but with my wife. And all of these areas that are involved and how we can get into a loop, where the complexities, the risks, I'm very aware of the risks as well, which is mainly that they don't have them in the right size, or they're the wrong color, or they're the wrong style, or I'm just not sure I should go back to the original store. But that's a different risk that we have to deal with. But the concept is essentially the same, and that we need to look at all the steps and see where we can get into loops, into bottlenecks, and into complexity. So when we map out a process flow chart, and when we're looking at complex processes, such as, for example, one that we were working on recently was in a radiology department where we were trying to improve the flow of information. People couldn't find records, etc. And the process flow went on for something like 15 pages. I'm not recommending that that be the case in all stages, but it certainly was significant. So we want to see what is the complexity and see how we can reduce that number of steps. So when we look at that, we can see where waste is, and the number one form of waste in all of these is time. So how can we reduce that? We also identify what departments are involved, and this concept of backflow. And backflow, we're back to the term again of non-real work. Non-real work, such as if they don't have them in the right size, you're back to doing it again. If the patient isn't ready, you're back to pulling them. If the records aren't in the right place, you have to go chasing someone. So it is that concept that can be clearly identified within process flow. So as I say, that is the key thing. If there was nothing else only to determine process flows, then it would be worthwhile. When we have a good understanding of the process itself, we can then and only then start to getting into identifying specific causes. And based on all of the brainstorming the process flows, we should now know or have a much better idea where the potential difficulties lie. So when we get into cause analysis, we're looking at both confirmation of our initial theory and also in case any other theories come up. The most common tools that are used for these are the fishbone or the ISQua diagram, multiple data collection and review, and that is certainly more than a presentation for today, and the data analysis that relates to it. The fishbone diagram. The fishbone diagram is a very practical way of identifying all the key causes and then to group them. It is essentially a cause and effect diagram. You require your brainstorming team again, people who have been involved in it in the different disciplines, etc. And it usually looks at categories such as, and you can vary them, the peoples, the machines, the methods, materials, measurements, etc. But it is a flexible thing. And there is an example of the fishbone diagram where we were looking at delay in test results and all the possibilities of what can cause it. So it gets an opportunity for people to group their thoughts together, to focus it, and to provide a grouping of potential areas for rectification. So another job for you, if we had loads of time this morning, or if we had a couple of hours, we could talk about developing the ISQua diagram. When we've started to identify where we are reasonably confident that our problems lie, we need to actually back that up by data. So it's still only a hunch. It's a hypothesis. We need to be sure of that hypothesis before we start investing a lot of time and energy into actually rectifying the problem that we have identified. So we need a basic tool for data collection. And that data, in God we trust, all others bring data, as I say myself, should give us a clear indication. So this is not research, and it's important to remember this. This is to give us good indications of where the problem lies. So there are lots of things there that we need to actually consider when we're gathering it. But what we should have is a basic aim, what the fields are required for, how we want to analyze it, and ideally have time to pilot that information. The data tool is varied depending on what organizations are looking at. But at a minimum, you need to be clear. You're going to hand out a form to some people, some staff in your organization to give you information. You need to keep it straightforward. You need to have it clear and uncluttered and no more than an A4 piece of paper if you're gathering information. People will not give you the time. So if you're looking at the two examples on screen now, they're very simple examples of gathering data with regards to delays of delivery of medications from pharmacy, etc. And there are two types. There's one which is used for every delivery, and the other is an amalgamation of it. And you will see on the right-hand side that it's already starting to get into some form of data analysis, which unfortunately we won't have time for today. Here's an example of how not to do it, and I'm not proud to tell you that this was one that I did myself at a very early time in my career, which was with regards to an evaluation of door-to-needle time. We were trying to improve the door-to-needle time for cardiac MIs, but unfortunately there was so much information that I was hoping to get that I got very little back. The reason that I was trying to gather so much information was that I hadn't carried out the first couple of steps. I hadn't analyzed the process enough. I hadn't done enough brainstorming. I hadn't focused on what I felt were the key areas. As a result, I was hoping that the data would point directly where the problem was. This doesn't work. And in some cases, I got a door-to-needle time, which should be an average of 30 minutes, ideally, of 3 days. So I just was not getting the information. So you need to keep it simple. Another example of the benefits of keeping it simple are simple stratification. So here we were talking about lab result delays. And we can see, even by gathering this, that it will direct us some very specific information. In the case that immunology has the vial damage rather than the overall laboratories have a delay in it. So stratification is just a nice word for saying let's group our potential areas that we're looking for. Again, we can't do this until we have the work actually carried out. Sorry, Joe, again, I think you have taken control there. Okay. Many people focus on the need for questionnaires, staff surveys, etc., and patient surveys. Again, these are fine, but please remember that they are subjective, that it is good for additional information, but it should not be your core basis. And certainly patient surveys, have a limited response. If you're getting 40% return on postal, it is a good result that you are getting from it. Again, with regards to the valid and reliability of the questions is important, and it is something that occurs with people putting in double-barrel questions, etc. So there are some examples there which I'm not going to go into about different levels, but the key thing from that slide is that this was a case where a data evaluation was supplemented by a patient and family evaluation. So when we have gathered that data, we have to be considerate of, should it be retrospective or should it be concurrent? And the key thing there is with regards to your time. If the process has been consistent over the last number of months and years, then it is quite easy to do retrospective data if it is done. But after that, you need to start to look at it. Now, Joe has just informed me that it is now 8:30, so I just want to hit on a few key other points over the last 2 minutes, and then we will be able to take some questions. Sampling. With regards to sampling and gathering the data, again, it is not research. It is important to know it is only a representative sample. So you try and get as much information as time will allow to give you a confidence that if you were gathering more information, that it would give you a similar scenario. Its randomness is important, that it's not all one day, and that it is representative. How much time that you can actually utilize for all of that is very much based on how much time you have. One of the key aspects of when you get that data, though, is please remember to validate it. Go through each one and see if it makes sense. I go back to my door-to-needle time study where I was getting a door-to-needle time of 3 days. I did not review the data, and as a result, I started getting some very weird results. When we start getting into data analysis, and the book that I can certainly recommend is The Fourth Generation Management by Brian Joyner, there is some very simple data analysis that can be used on the types of forms that we're talking about, and looking at the numerical data in a logical sense. So again, we're still, believe it or not, have not made any changes to the organization. We're analyzing the data. We're using the likes of the check sheet, the qualitative data, etc., and we are gathering the information. One of my favorite uses of data analysis, and again, unfortunately we're out of time today, but for another day, is the use of scatter diagrams, which will allow you to look at correlations between your hypothesis and some of your findings. In this example here, we tried to look at the turnover time in minutes against the call for next patients. This was in relation to turnover in a theatre, and we found that there was a correlation. So simple scatter diagrams, simple analysis can work quite effectively. So when we have all of these solutions, and this is where I'm now coming to an end, when we have all of these brought into effect, we've identified where the actual problem is. We then go about addressing these, and we implement these through other tools that we've already, and some that we've used already. So it is a project management approach with regards to education, implementation, focusing. The project management is a key aspect of this. So what I would say to you, and apologies running a little bit over, is that by undertaking a quality improvement initiative, the most important aspect of it is in the planning. And when we have narrowed down and focused what we feel are the most beneficial aspects of making that improvement, then we will utilize our time well. Quality improvement is not, here's a problem, I have the solution. Quality improvement is, here's a problem, is it really the problem? I don't know what the answer is. Let's break it down. Let's use core principles. Let's do it in stages. Let's come up with a hypothesis. Let us test the hypothesis. Let us make that improvement, and let us ensure that that improvement is what we need and that it continues to go on. With that, I'll stop and I'll hand you back to Joe for any questions.
Thank you very much, John. This is very interesting. And I'm just wondering whether there are any questions that any of our attendees have for John. If you have any questions, you can either type them or raise your hand. There doesn't seem to be any questions. Okay. No, we don't seem to have any questions at the moment. So if anyone has any questions, please don't hesitate to contact John directly We will also open the forum, and again, if you would like to discuss anything